Hello, dear viewers, dear colleagues, dear friends. Me, Mostafa Neouchi, I want to welcome you today for our discussion, which is really important and really very interesting. Me and my colleague Matt Holden today from School of Education will discuss it and talk about it more. Our topic of today is atrial fibrillation and its relationship with sudden cardiac death. As we know, atrial fibrillation is the number one most common arrhythmia in the world. And we know that it has a huge impact on the heart overall, and it has the power to cause an increase in falls and mortality. And as we know, that also atrial fibrillation can increase the risk of having sudden cardiac death. How? Let's discuss it. As we know, atrial fibrillation is known to cause clot formation in the left atrial appendage and will cause this clot to be mobilized in the left ventricle to the aorta to the brain, which can cause a severe ischemic stroke. This severe ischemic stroke will cause cardiac dysfunction because it can hit the insular cortex, and this can play a role in causing sudden cardiac arrest and sudden cardiac death. Overall, other than that, patients with cardiomyopathies, especially hypertrophic cardiomyopathy that come with atrial fibrillation, will have a higher risk of developing sudden cardiac death because the nature of the heart that needs more oxygen to pump due to these hypertrophic cells and myocytes need more oxygen, need more supply. And due to the fact that they have the potential to also squeeze the coronary arteries. And when we have also the setting of atrial fibrillation with rapid ventricular rate, this may also cause stress and the need of having more oxygen and more blood supply. And we know that in atrial fibrillation, there's no adequate blood supply from the heart and to the heart, which is severe and can play a severe role in causing severe cardiac problems and cardiac arrest. Not only just because of the need of more oxygen and supply, and also the fibrotic tissue have the potential to cause more bypass for this atrial fibrillation as well. As we know as well, atrial fibrillation can induce cardiomyopathy and can be related to cardiomyopathy. As we know, like by example, patients with dilated cardiomyopathies, heart failure, and so on, can be having also atrial fibrillation. This atrial fibrillation can rather cause and be a factor of heart failure, cardiomyopathy, or vice versa. As we know, by example, atrial fibrillation can play a role to be causing arrhythmogenic induced cardiomyopathy, or basically atrial fibrillation induced cardiomyopathy, which is some type of heart failure, okay, induced mainly by atrial fibrillation. Because atrial fibrillation plays an atrial remodeling and the dilation of the atrium, and it can cause decrease in cardiac output and contractility and inadequate blood flow to the heart and from the heart to the organs, which is a problem and can increase mortality for the patient. Sometimes when the patient have some type of valvular pathology or valvulopathy, like mitral regurgitation or stenosis, this can cause atrial fibrillation due to the pressure on the atrium, and this can cause atrial remodeling and can induce atrial fibrillation. Still, they can get increased risk of mortality and sudden cardiac death as well due to the cofactors present in the heart. Other than that, patient who present with Wolff Parkinson White, basically an extra accessory pathway, and get atrial fibrillation, have a high risk of sudden cardiac arrest and sudden cardiac death. Because when we have this extra pathway and we have atrial fibrillation, as you know, the AV node is trying its best to control this atrial fibrillation that is beating with a rapid rate. Yes? When we have a pathway, these fibrillatory waves will find a way to the ventricles faster and more efficient than the AV node because there's nothing blocking them when we're using the pathway. So more impulses will arrive to the ventricles and there will be no blocking, which will cause severe ventricular dysrhythmia and tachycardia, which can cause cardiac arrest and death. So what should we do? First of all, anticoagulants. Anticoagulants are gold standard to treat or to prevent, a way of prevention of blood clot formation in the left atrial appendage. Like basically novel oral anticoagulants, which are NOACs, which are factor 10A inhibitors, which are like rivaroxaban, apixaban, vendoxaban, and so on. And if a patient is present with valvular atrial fibrillation, they should take warfarin or synthron. So on. Other than that, to treat atrial fibrillation itself, we have two approaches: rate control, rhythm control. Rate control plays by using beta blockers, by first of all calcium channel blockers, to help us control atrial fibrillation and slow down the rate. Beta blockers like what? Like metoprolol, propanolol, or even like bisoprolol as well, which is also good. Calcium channel blockers like diltiazem or verapamil that plays good in the management of the rate of atrial fibrillation. Also, we can mix it or give out a digoxin, which is an inotropic, and help us also control the atrial fibrillation by giving an inotropic effect to the heart and slowing down the rate. We can mix them rather like, by example, a beta blocker and digoxin. But also just be careful of the digoxin effect because it's known to have some secondary side effects on the heart, which are not very pleasant. Rhythm control or rhythm approach can be used by rather sodium channel blockers or potassium channel blockers like flecainide, procainamide, or the known amiodarone, or, by example, the dronedarone. These medications help us convert atrial fibrillation to sinus rhythm and maintain it. And can be, by example, an amiodarone can be given with a beta blocker to maintain rate and rhythm control. Patients sometimes can be candidates to cardioversion, but before they should be anticoagulated for 3 to 4 weeks, then doing an elective cardioversion to then get this atrial fibrillation sinus rhythm. Other than that, people who are not anticoagulated and need an emergent cardioversion should do a transesophageal echocardiography and should do cardioversion to see if there's any evidence of clot. And any patient who do cardioversion without any prior anticoagulation, they should start anticoagulation after cardioversion to 3 to 4 weeks. Last thing, patients with Wolff Parkinson White or any accessory pathway should get an ablation to prevent this atrial fibrillation from causing sudden cardiac arrest and increased falls and mortalities. And it is preferable to use prophylactic beta blockers, by example, to maintain and prevent and keep the patient safe for a longer time or more as much as we can from causing dysrhythmias induced by accessory pathways. And thank you.
Hello everyone, my name is Matt Holden. I'm one of the co-founders of Scope Education. I wanted to thank my friend Mostafa for giving a great in-depth view on AFib and sudden cardiac death. So it's my job now to kind of break down a couple of the topics. So first off, what is atrial fibrillation? Essentially, it is the shaking of the top part of your heart. You're just going to create an irregular heart rate as well, as you can see by the AFib rhythm on the bottom. Some of your risk factors include like your hypertension, which is your high blood pressure, your valvular heart disease, your cardiomyopathy, sleep apnea, holiday heart syndrome, which is essentially when you drink too much alcohol, which can cause you to go into atrial fibrillation, and thyrotoxicosis, which means that there's too much thyroid hormone, which puts stress on your heart. We want to keep your heart rate less than 80 beats per minute, and we can also give medications to convert you or use synchronized cardioversion, which is electrical therapy to get you out of atrial fibrillation. Now, once again, my name is Matt. I would like to thank Mostafa and the CardioVisual community for putting on this event, and I hope you guys have a good day.